Okay, yeah. So welcome, guys. Thank you for joining in for another session with us. Today we have quite an important guest with us, Dr. Paymon. Here, talking about him, he's quite popular in social media. If you're not aware, he has a great website, RAD, which is primarily focused on promoting FRCR training program. And I think currently he's primarily focused on the anatomy, the rapids module, and slowly he's trying to expand, I think, to the VIVA session as well. So, and we are really happy to have you here with us and give your share of feedback. Probably, I think it might help a lot of candidates for coming up for the September and also for the Jan session as well. Having said that, he has been now working for a couple of years in UK, and currently he is a senior lecturer, clinical lecturer in Northwest School of Radiology in Liverpool. So I think I'll hand over the mic to him and let him do his set of introduction before we start with the session. Over to you, Paymon.
Thank you, Nikhil. Thanks for having me on. Thank you and Dev for both letting me come on today. So nice to meet you, everyone. I'm sure maybe some of you know me through social media, like Nikhil was saying, but probably not. But anyway, my name is Paymon. I wouldn't call myself important, but I do like radiology teaching a lot, and I am senior clinical lecturer for the Northwest School of Radiology, and I do a lot of teaching for the ST1s, 2s, 3s, and 4s, and I do a lot of 2B teaching as well. And like Nikhil said, I've made a website as well, which we'll talk about a bit later. But I am from all around the world. So just a little bit about me. I was born in England, in Manchester, lived here till I was 8 years old. Then I moved to Spain for 2 years, then Cyprus for 10 years, and then I studied medicine in Czech Republic in Prague. So I've had a variation of almost all of Europe, okay? And then I came back to the UK to do my F1, F2, and also to do my radiology training. So I've been here for about 7 years as a doctor as well. I'm about to CCT in a month's time, so I'm coming towards the end of my training, and my GI is my subspecialty interest. But without further ado, I will continue with the actual presentation. And what I want to do today is focus. The first part of my talk is mainly going to focus on the rapids. And the reason I want to do this is because this is where candidates usually fail. The Vivas, a lot of it's about technique. So it's how you present yourself. It's about being a safe radiologist. It's about, trying to show how you think and your rationale. The rapids, unfortunately, is one of those things that, if you fail it, your chance of passing the exam is very, very low. So I really encourage candidates to focus on the rapids a lot because that is what will get you to make sure you secure that you will pass the 2B exam. And a little bit more, I'm sure you already know, you've got 30 cases to do in 35 minutes. You have a mixture of normal and abnormal films. About 13 to 15 are going to be normal, and the rest are going to be abnormal. So usually there tends to be a few more abnormal than normal. It's not always the case, but that's usually what happens. And a majority of the films that you're going to get are going to be trauma films. Only some are X-rays, chest X-rays, and that majority of the films that you'll get will be peripheral films, so knees, ankles, blah, blah, blah. Remember, anatomical variants and any age-related degenerative changes are normal. So an azygous fissure, it's normal. You don't write abnormal and that will lose you marks. So be sure that anatomical variants and age-related changes, you just call that normal. Sometimes you may have a single pathology or you may have multiple related pathologies, but those multiple related pathologies have to be the same disease process. So what I mean by that is, let's say you have a fracture of a metacarpal, you may have consecutive carpal fractures. You will not have a fracture in one place and a bone tumor somewhere else. That's not allowed. It has to be related. So a fracture dislocation is allowed when it's associated with one another. In the whole exam, you have obvious, intermediate, and subtle pathologies is how I like to kind of describe it. So subtle pathologies are, things that, you kind of very difficult to see, you have to actually really focus in on Zoom. Intermediate is just a fracture that you would expect to get, and obvious things are very obvious, like a huge mass and something very obvious. And out of those, probably about 2 to 3 will be obvious, and 2 to 3 will be subtle. The rest are just going to be your bread and butter intermediate stuff. And what's important here is what I really want candidates to focus on is that subtle pathologies, even though they're subtle, they have to be definite. So what I like to tell people is if you see something and you're not sure, picture you're sat in a room of like 5 other radiologists or 5 other colleagues, and if you see something and show it to them, they should all agree with you. They should all be like, yeah, yeah, good spot, but it's there. If you see something that's a bit ambiguous and you're not sure, and you sat with your friends and say, hey, look at this, and then there's dispute among your colleagues, and someone says, maybe, and the other one's like, no, I don't think so, then don't call it. Just call it as normal. Okay, that's a really important, that's probably one of the most important take-home messages. I'll reiterate it again later on, but I want you to remember that bit. So a few tips and tricks I want to give you guys is number one, don't be lazy, okay? Outline the cortex of every single bone on every single view. Okay, it's very easy to get, taken away and be lazy and just be like, oh, it's normal. But seriously, outline the cortex of every single bone on every single view. Sorry, Nicola, I know the chat's lighting up. Is there anything I need to be aware of? I'm sure you'll keep track of it, but let me know if there's any questions on there that I need to address. I'll peek quickly. There's a lot of things. All right. Is asymmetric situs inverters considered a variant? You know what I'll do? I'll finish my presentation, guys, and then I'll go over all the questions later just so that we can get through them. So feel free to write whatever you want in the messages. And unless there's something really urgent, I'm sure Nick will let me know. Otherwise, I'll come to the end and answer those questions individually. So yeah, be sure to outline the cortex of every bone, okay? Don't be lazy is the point. Don't be lazy, seriously, guys. Because that last bone on the edge of the film might be the bit that you miss, and that's where the pathology is. I really want you guys as well to remember how important your secondary signs are, okay? So things like a bandage, that already alerts you that, maybe there's something going on. Make sure you look for effusions. If you've got an elbow effusion, you need to be alerted that there's most likely going to be radial head or neck fracture. In an adult patient or in a pediatric population, be suspicious for supracondylar fracture. Look for your soft tissue swellings. Look for surgical emphysema and any foreign bodies as well, because these secondary signs will help you. Let's say you see that subtle pathology, like, I'm not sure, but then they have soft tissue swelling and effusion, then you need to be sure now that those secondary signs help you to be sure that there is a pathology there. So another thing I really want to another good tip that I think I only really learned towards studying for this exam. I wish I knew it sooner in my radiology training, but unfortunately I learned it a bit late. And that is the importance of the trabecular pattern. Okay. So your trabecular pattern forms a unique fingerprint of the bone. And the moment you see linear lucencies going across or things that are disrupting this normal trabecular pattern, you really need to be alerted that there's probably a fracture there. This in itself is sometimes it can be a bit subtle and you're not sure, but if you have different views, this should really alert you that there is an underlying fracture there. So trabecular pattern, really do focus on it and pay attention to it. Again, what we talked about before, make sure you don't have satisfaction of search. If you find one fracture, make sure you look for multiple fractures which are associated with that disease process or that fracture pattern or the injury that's occurred. So again, multiple metacarpal fractures is a good one. Multiple tuft fractures is another one. Dislocation associated with a fracture is another one. So just make sure you don't find the fracture and then move on. Be systematic and look at every bone, outline the cortex, and be sure there's nothing else to add on. Because if you only say one fracture and there's two, unfortunately, you don't get the points. Another thing that's very important is the edge of the films. So, you have a chest X-ray, but the fracture is actually a clavicle fracture, or you have an ankle X-ray, but it's a base of the fifth metatarsal fracture, or just make sure that you're looking at the edges of the film and make sure you cover everything and be sure you're not missing any little things that will get you that extra point. So what usually happens is people tend to be overcallers rather than undercallers. So a lot of time people fail because they thought they saw something and then they called it and turns out that was just normal. So what I really want you guys to do is try to get that balance right and become that perfect balance of being not being an overcaller and not being an undercaller. But like I said, majority of people tend to be overcallers. And sometimes the reason of that is because, a lot of the practice exams online, there's a lot of subtle pathologies. When you come to the exam, you tend to overcall. But what I want you all to remember is that no matter what happens in the exam, all the questions get reviewed by a group of radiologists, a board essentially. And all they do is to make sure that there's nothing ambiguous. So if there is something that they're not sure of that ambiguous or wasn't sure there's no pathology, that gets taken out of the exam. So just don't overcall. Remember, like I said before, picture you in a room of 5 other radiologists or 5 other friends, and the moment you see something, everyone should agree with you. If ever there's a dispute among your colleagues, just say it's normal and move on to the next case. Okay? So I'm gonna skip this bit and go straight to the website because it's all updated on there now. So yeah, so like Nicola was saying, so I've created this website which I would recommend you all to try out yourself, but I'll give you a quick update on what it is. So there's this image page which we've just created, which is completely free for anyone to use. You can go on here, you can click on here, and it has basically all the regions, and you've got your anatomy, if there's any relevant regions, some related illustrated pathologies. So these were all illustrated by myself, and then you can look at the answers and labeled. And I really recommend you all go through this in your own time. It's a good way to learn and look for different things, and it's a great way for you to just practice different things. You can zoom in and use all the functions that you would expect in a normal DICOM viewer. And a nice case, I guess, is a chest one. It's quite easy and everyone loves it. So anatomy, you've got some nice review areas, and then pathology. I'll open this one up to everyone because I think it's nice. So there's 6 pathologies on here. I want to see if you got keen eyes and see if you can get them all. So there's 6 pathologies on here. I'll leave it to the floor for you all to write in the chat or if it's going to take too long, I'll just shout them out. But hilar nodes, great. So yeah, so you've got hilar lymphadenopathy, pneumoperitoneum, pneumothorax, retrocardiac capacity, great. We've got 2 more left. 2 more. Right, hilar nodes, right rib lesion, very good. That's usually the last one. So great. So a right missing rib here. I think it's a 1, 2, 3, 4, 5, 6, 7th rib. If I'm not mistaken, and then left apical lesion. Perfect. That's all 6. Beautiful, guys. So I recommend you just go check out the website. Feel free to have a look. It will help with your training. And then for those of you who are keen and more interested, I've also created some rapids. So you need to sign up to use these. There's one for free. And then if you want to use more, unfortunately, in order to run the website, I have had to put a little fee on them. But check them out and feel free to use them and let me know. So you can just the goal when I made this rapid packets was basically to simulate the exam as much as possible, but to make it a bit different. And the idea was to make it more user-friendly. Unfortunately, the exam isn't as user-friendly. But the idea is that a lot of the packets that already exist out there, they don't have multiple views. They're missing a lot of things. So I've tried to basically make it as replicative as possible. So you get multiple views. The subtle pathologies should be definite as well. So a lot of the exams I've created try to replicate a typical packet in the exam. Again, there should be quite a lot of pediatric films you get as well, and a mixture of films. And like I said before, it does everything you need it to do. You write normal, abnormal, and then you go to the end. And then once you've finished your exam, you can click submit, and then the answers get marked for you, and then you can see your responses, and you can see you can see all your answers. So this would be a review page. So you can see that you get your answers, and you can go back and forth and see how you did. So yeah, check it out. I'm sure it will help you with your exam, so I really do recommend it. And remember those principles and things I told you guys. It's really important. Don't overcall, and make sure that you just picture yourself in a room of 5 other radiologists and don't overcall. That's the serious, most important thing. Just don't be an overcaller. But yeah, that's more or less the main things I have to say for the rapid. So if there's any questions for the rapid component, I'll take those now. Otherwise, we can go straight to the VIVA component. I'll just put a link in the chat so everyone can just go on the website themselves in their own time.
I think it was a
Let me
great
go back to the
session,
top. I know a
Paymon.
few people.
I think I'll probably ask you a question. Probably, I think everybody would be concerned about. So there is a general idea that the ratio of the normals and abnormals that can come up in the exam. What is your take on that?
So I've taken what is written by the RCR. So if you look on their website, there's only about a paragraph about what they've specifically said. And the thing that they have specifically said is that statistic I had of about 13 to 15 are going to be normal and the rest will be abnormal. That is the thing they've actually stated on their website. The other thing they've stated is that a majority of the films will be peripherals and a few are going to be other things, so abdo X-rays and all that actually stated in black and white on their website. So that's something that actually they should follow by and abide by. And it's also what I witnessed in my exam too. So I did manage to get 30 out of 30 in my exam. So it is possible, guys.
Wow.
And that really puts you in a really good place. So then once you've done that, you know, you're pretty much almost guaranteed to pass if you don't get really unlucky or something happens. So just be systematic, you know, outline the cortices of the bones and make sure you don't overcall. Because I remember when I came out my exam, a lot of people, oh, there was an enlarged psoas shadow. You're not going to have an enlarged psoas shadow. If it is, it has to be the most textbook enlarged psoas shadow you've ever seen in your life. Otherwise, it's going to be so ambiguous, you know? It has to be something definite. If it's subtle, it will be definite. So is asymptomatic sinus inversus considered variant? So I think sinus inversus is a bit difficult because sinus inversus can be associated with so many other pathologies, heart defects and malrotation, a lot of things. So I think it's a bit difficult to put that on in an exam as thing. But dextrocardia in itself, or you know, a right side aortic arch, those are a bit more. I'd probably call them normal. But again, I think it would be very, very unfair for them to put those types of things in the exam. But nasogous fissure is fair. It's never associated with pathology. It's always good. But things like, left-sided, well, you wouldn't see that, but like dysphagia of the sora, you probably wouldn't see that on an X-ray. But things that are associated with pathologies, it's unfair for them to have an exam. So like a sinus inversus, not fair. They would have to take that out, I think.
Yeah. I think probably another question that might come up is there are a lot of what I personally felt with my exam is a lot of pediatric radiographs are coming up in the exams, and I think most of the candidates
Yes.
literally struggle with pediatric radiograph. Do you have some tips that you could give them as to handle how the radiographs when it comes to pediatrics?
It's a good question. So I think about 20 to 30%, even 20 to 40% are pediatric films. And the thing about pediatric films is it's just the more you see, easier it gets. The thing that a lot of candidates struggle with, or when I'm doing a lot of teaching, is especially when you start first looking at pediatric films, is how weird the metaphysics can look normally, how weird the epiphysis can look with like multiple lines going through sometimes. And or if you have like a pelvic X-ray and you still haven't got your apophysis fused or your iliac crest still isn't fused, and people mistake those as pathologies. And the thing is just getting experience and looking at as many films as you can. So I've tried when I've created these rapids is to have a lot of pediatric films in. So if you do use RAD bites, you will get a little bit more experience with using those pediatric films as well. And again, it's just about practice, 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 and getting your eye in for that normal metaphysis and normal and how they look.
Yeah, I think we have one more question.
If not,
If in case of
yeah.
oblique radiograph, how would you give the counts of metacarpals or phalanx if it happens to come?
So you never get a single oblique view. So this is what I'm trying to say. So a lot of the practice exams out there, you have a peripheral film and it's just a single view. That's not going to happen in exam. If you have a peripheral film, it's going to be like real life. You in your daily practice, you would never be expected to call a fracture on a single view. That's bad practice. And they don't try to do that in the exam. So all peripheral film should have multiple views so you can identify those associated pathologies and fractures. So yeah, it's not just going to be a single oblique view. You would have multiple views. If the side's not mentioned X-ray, we'll just mention fracture. Yeah, so if the side's not mentioned, don't mention it. If the side's mentioned, there's no harm in mentioning it. I know some people said that, it's not necessary to get the points, but I just wouldn't risk it. I tell this over kind of, if it's also like, if you know there's a right side, say it's the right side. Because what you don't want to do is not say it and then you lose a mark for it or lose 2 marks for it. It's just not worth it. So easy to write right to left if you're sure. If you're not sure because there's no laterality or no sign, do not say it because then you will lose marks of being incorrect. So be sure, only do it if you're sure. Another question is, do not do abbreviations, okay? Don't write OA, erosive OA, write osteoarthritis. Spell it out. Don't use abbreviations. Should we describe a fracture? Right, and sure. Describe it, but you don't have to be literal. You don't have to say, there's an oblique fracture with a twist and blah, blah, blah. Just keep it, metacarpal neck fracture. You don't have to say it's displaced. You don't have to say all the extra bits. That's enough information, but be anatomically correct. So is it metacarpal? Is it head? Is it neck? Is it base? And be accurate. And the only time I really I tell my students to be specific is if it's intra-articular, because intra-articular fractures change management a lot of the time. So if there's ever an intra-articular component, I do say spell it out because that might help change management and is relevant. So should we describe blah, blah, blah? Spell check for longs and rapids are okay. So if you've got some mistakes, like little spelling mistakes, they don't mind. It's fine. As long as it's not a huge difference, like, ilium and ilium, that's a different organ. So instead of saying ilium as in the bone, you say ileum as in the bowel. That can be a little bit, tricky. But if it's literally a few spelling errors, it's fine. Named fractures terms like will play injuries. So do not use eponymous names, okay? I really recommend do not use them. The reason is because sometimes for it to be a true eponymous names, it has to have specific things for it to be called that. So a perfect example, like a metatarsus fracture or galactic fracture, if it doesn't have the associated dislocation, it's not true. So even in our daily practice now, we've kind of gone away from using these eponymous names, even like boxers fractures or chauffeur's fracture, whatever. Just say what it is. Just say, fifth metacarpal neck fracture. It's good enough, metacarpal fracture of the ring finger. Sorry, little finger is perfect. You don't have to go into eponymous names. It's not good, and you might lose the points for doing that. Yeah. So description is better. So say volaprate injury, blah blah blah. Okay, so isolated joint fusion. So that's a good question. I think a lot of the time, if it's just isolated joint fusion, yes, write it. But I can't imagine that they would just give you an elbow fusion without an associated fracture because the whole point is to teach you from the fracture. So if you see an elbow fusion, really, really look for that fracture there. It just might be a little bit sneaky. And an effusion, yeah. So another question is if you have an effusion, just mention it as well. So let's say you have an elbow fusion. The main thing here is saying the radial head fracture if there's a fracture, but also I would say just add the effusion on as well because you won't lose marks, but you might lose, like for like a lipohemorrhosis because it's such a specific entity. If you don't see the lipohemorrhosis, you probably will lose marks. So if you have a lipohemorrhosis, mention it with a tibial plateau fracture, mention both of them. Fibrotic infarction, yeah, you can say fibro, but you could just say vascular necrosis off the head of the second metatarsal, whatever it is. You don't have to say fibro. You can. It is eponymous, but it will be good enough. But maybe just say avascular necrosis. It's the same disease process. Why say fibro? You'll probably misspell it anyway, like I do. I'm awful at spelling, so. All right. Well. Sometimes there's a confusion between head versus neck and metacarpal neck. Yeah, so if it's close enough, they're not going to mark you down for it. Like I think a really good example is also head and neck of the radius. There's no proper anatomical definition of where does it exactly end and where does it begin. So if you say head or neck and it's close enough, they won't mark you down for it. It's not fair. They'll have to give you the points. Yeah. Yeah,
Yeah.
with neck though, it's different. The main thing is distinguish is it intracapsular or extracapsular? Because again, that changes management. But if you're saying, subcapital, subtrochanteric, doesn't matter. Just is it intracapsular, extracapsular? That's what we really care about because that changes if it's a DHS or hemi arthroplasty.
Great. So I think probably we'll take another one or two questions and then we'll move to the Viva. What do you say, Paymon?
Yeah, that's great. I'm here to help you guys. Whatever you guys will
Yeah, I think
benefit the most out of me,
exactly. Yeah.
I will help
So
you guys.
meanwhile, if you keep getting questions regarding rapids, you can keep posting in the comments, and I think we can just move on with the Viva right now. So is that okay?
Sounds good
Shall we
to me.
proceed with it? Yeah. So
Yeah, sounds perfect to me. Let me.
yeah, Dr. Vivek, are you there? Could you, Dr. Vivek?
Hello. Yes.
Yeah.
Hi,
Hi,
Dr.
Vivek. Yeah.
Nikhil and Dr. Paymon.
Yeah.
Good evening.
Thank you for having. Thank you for being here, Vivek.
So is that Vivek first?
Yeah, this is your first candidate. Yeah.
Perfect. So what I'll do is I will share my screen. Don't want you to see that yet. So let's get you let's give you control first. Although it doesn't matter in this case because it's just a plain film. So if you're happy, we'll do you, Nicholas, you want me to just do one candidate, one case at a time. Is that correct?
Yes. Yes. Let's do that. Yeah, so that everybody gets an opportunity with you.
That sounds good. So yeah, I like, so usually what I normally do, but obviously not today, I try to do, because there's only, usually I do smaller groups, so I try to give them a taste of how an actual exam is. So I actually do a timer and give you guys an actual, like, exam experience. But obviously today, because there's so many of you, I think it's better to give everyone a little taste. We'll do a case each. And then, maybe in the future, if Nick likes me and wants me back on, maybe we'll do that another day. But we'll take that, we'll take each day as it comes. So what I'll do is I'll share my screen, give you the first case. I'll give you a little history, and then I'll let you just talk it through. Okay. A little tip I just want to say about the VIVA as well, because I think this is very important. So remember, a lot of the VIVA is about technique. Okay, it's about how you're communicating it across and what you're letting the examiner know. They want to see how is your brain working. Are you a safe radiologist? And are you going to be ready to basically, become a consultant? This is what this exam's for. It's that, step of, finishing your training or becoming a consultant, or whether you're a consultant in another country, coming to the UK and, integrating within how we do things in the UK. So that's the whole point of of this exam. And what I recommend people to do is it's your normal thing is, you get the case, you get a history, and then take the time to quickly look at the film, give yourself a few seconds or whatever, and then start talking. And then when you start talking, go straight to what's relevant. Don't, if you have a CT scan and, the pathology is in the pelvis, start talking about the pelvis. Don't start talking about normal things in the top of the scan. It's a waste of everyone's time. And, it's not great for you. The more cases you get through, the better. So go straight to the pathology, start talking about it, and then let's see where it goes. Okay. So Dr. Vivek, if you're ready, I will
Okay.
leave the floor with you and exit that. So here's your first case. The patient has jaw pain.
Okay.
So Vivek, are you there? Yeah, cool. Yeah, go ahead.
So I've been provided with orthopentogram. Yeah, I've been provided with orthopentogram. Let me just review my areas once. With the patient who comes with jaw pain. So let me just review the mandible. Yes, those striking abnormality I'm looking here is there is a well-defined lucent lesion in the ramus of the mandible on the left, without any sclerotic borders. The internal matrix, although I'm not very certain, it is a glass and sclerotic regions within the lucent lesion. I do see some periosteal elevation or reaction in the lower margin of the ramus of the mandible. I quite don't see any evidence of pathological fracture there. Rest of the areas. Wait. Yeah, I do see some dental caps, dental implant caps. So summarizing my findings in a patient who has come with a jaw pain, I see there is a lytic lesion without sclerotic borders in the left ramus of the mandible. My first differential, I would like to think a possibility of a metastatic lesion. Second differential, I would like to think a possibility of adamantinoma. I would inform my findings to the referring physician, compare the prior imaging if available.
Okay, so it looked like that on prior imaging too,
Okay, so
done about a month ago.
okay, so I would ask if the patient has any primary neoplasm elsewhere. It could be myeloma, it could be lymphoma, it could be metastasis, which could likely be renal cell or thyroid neoplasm.
Is there anything else on the scan that may help you?
I'm just looking for any soft tissue. I do see some differential soft tissue attenuation there. So I would also like to think of possibility of osteomyelitis.
Okay,
If,
so if it was there a month ago, do you still think osteomyelitis?
pardon, sir, I didn't get it.
If the previous film from a month ago was exactly the same, do you think osteomyelitis is still likely?
No, no, unlike.
And what do you think about the rest of the scan? Maybe on the right side. Do you want to have a look on the right side? Is there anything on there?
Yes, on the right side in the soft tissue, I quite see two linear radio opacities in the soft tissue region, maybe above the hyoid bone. So I would I'm quite not sure what they are, but it might be artifactual or they might be some foreign body.
Okay. So what I tell you, the patients had previous surgery there. Those are surgical clips. Does that help you?
Yeah, so I'm sure if the surgical clips, my first thing that comes to my mind is the patient might have had a thyroid surgery. It could be because of the neoplasm. So this points more towards a metastatic lesion secondary to thyroid primary. Or
Okay.
if it is a parathyroid lesion which the patient had underwent surgery, then it could be a Brown's tumor.
Fine. What would you do next?
I would inform the findings to the referring physician and no, refer the case to the orthopedician for the further management and maybe suggest a further nuclear scan or PET CT if there are any interval new lesions or CT to see if there is any pathological fractures, as I'm quite not so certain that there is a fracture here.
Okay, fine. Thank you. So yeah, so
Thanks.
first case, good job. It's a difficult case, this one. I really like this case because it's those surgical clips really tie it together. So yeah, so you did great. You noticed the lesion really well. You know, there's a mixed kind of lesion in the left ramus of the mandible towards the angle. You know, it's got loosened areas and some sclerotic areas. Yeah, there's a little bit of ill-defined areas, you know, inferiorly, like you said, a little bit of repair extraction perhaps. And we've got these surgical clips here. So the main thing is also loss of teeth here. We don't know if that was before or after. But yeah, there's lots of dent of the teeth in that region. And this is a specific thing. So metastasis is fair enough. I think that's a very reasonable differential because yeah, very well they could have had you know, some form of head and neck cancer. It's a bit too high for the thyroid. So thyroid is going to be a lot lower down. So thyroid and parathyroid, unlikely. This could be, you know, metastatic nodes which they removed, but is actually a head and neck cancer the patient had. And this is actually due to radiotherapy changes. So this is what we call you know, osteoradionecrosis of the jaw. It's a very typical entity. And the thing that you take home message here is it's usually mixed and there's usually volume loss, which is quite an important thing. So usually in metastasis, you get more, you know, it expands, it gets bigger, and the soft tissue changes because, you know, it's a more aggressive process. Whereas with osteoarthritis, the bone dies and then it shrinks because it's essentially dying, right? So yeah, so just think about that. Whenever you have a history of a patient with previous head and neck cancer, they usually get radiotherapy, and a lot of the time they get this osteoradionecrosis of the jaw. You can get a similar thing with bisphosphonate therapy as well. So just the thoughts to have as well. And metastasis, I think, is fair enough. Going down the thyroid and parathyroid route, again, that's lower down, so not so common. And an ameloblastoma is usually more soap bubble, it's more expansile and a lot larger, but fair enough differential as well. But yeah, good job. It's a difficult case to start with, but I like it because it's one of those cases that once you've seen once, put it in your memory bank for later, so you don't make so that you can run it off your tongue the next time. So good job. Yeah. Just a few points for you specifically is just for everyone. A lot of candidates, they do that where they get a film and the first thing they say is the most striking abnormality or the most obvious abnormality. There's no point saying that, you know, when you're in an MDT and the consultant's there and someone presents a case for him, is like, oh, hey, have a look at this case. They're not going to be like, oh, the most obvious abnormality. Just say there is or there isn't. Tell me what there is and tell me what there isn't. Be confident, you know, show me that you're ready to be a consultant MDT. And that's the idea, right? Just, you know, sounds smooth and good. And yeah, but good job otherwise.
Okay.
All right. Should we go to the next one?
Yeah,
Thank you very
sure.
much.
Yeah, thank you, Dr.
Thank you.
Vasek. Yeah, Dr.
Thank you.
Varsha, are you there? Dr. Varsha?
Yes, I'm there.
Yeah.
So this time we will need you to share your give you control of my screen. Do I need to do that, Nicole, or can you give the candidate access?
Yeah, just a sec. Yeah.
I have requested control.
And let's control this computer. Is it gonna be one of these? There we go. Access.
I think you might get it in on the Zoom itself, Dr. Paymon.
I think you should go. Do you want to try?
Yeah, I'm actually trying to see.
I think I can scroll. Yeah.
Yeah, you can scroll.
Perfect. That's what.
Great.
Okay. So this is your case, and the patient has come in with abdominal pain.
So I'm presented with the contrast enhanced CT scan in axial sections. I'll scroll down once to see the pathology before commenting. So, so I see that there are multiple dilated bowel loops, small bowel loops, which are normally enhancing. There is no evidence of any ischemia, the nematosis or pneumoperitoneum, no portal venous gas. The transition point is located in the distal ileum. At the site of transition point, there is a bowel loop herniating into the femoral canal. It is lying adjacent to the femoral vein. So it's probably the femoral canal where it is herniating, and distal to it, the bowel loops, small bowel loops are collapsed. This hernial sac, in the hernial sac, the bowel loop shows some heterogeneous enhancement with some fat stranding. So there might be some impending strangulation at this site. Also, I can see some surgical clips at this location as well, which might represent a previous surgical procedure. Apart from that, I'm not able to see any other significant pathology. There are some calcified nodes in the pelvis with some diverticulae, sigmoid diverticulae, but there is no evidence of diverticulitis at present. And okay. Apart from this, there is no other significant pathology. There's mild left-sided hydronephrosis, but mild dilatation of the left pelvic calyceal system. There is, in my routine practice, I will also look at the lung windows. There are some pleural plaques seen in the bilateral anterior pleural surfaces.
Okay. Ignore
So
those.
my finding. So in conclusion, this is a case of small bowel obstruction, probably caused by a obturator hernia, right obturator hernia, which shows some impending signs of strangulation. This is an emergency. I would immediately pick up my phone and inform it to the clinical team. This patient will need an urgent surgical referral for further management. Thank you.
What type of hernia did you say it was again?
Sorry?
What type of hernia did you say it was again?
It was a right femoral hernia.
Correct. You said operator later on. I agree with you. Can you tell me your landmark between a femoral and inguinal hernia?
So femoral hernia generally lies adjacent to the femoral vein, and it causes some compression of the femoral vein. And the hernial sac would be located below the pubic tubercle. I think this is arising above the pubic tubercle. So this would be a indirect inguinal hernia rather than and think the inferior mesenteric artery.
Okay. So do you think it's
The hernial sac is medial, so it's a direct inguinal hernia.
okay? Are you sure?
Yes.
Okay, fine. So yeah, you did great. I think I made you stress out more than you needed to be. So it's a femoral hernia. You were right the first time around, completely. So I'm just gonna take control and walk you through it. But really good job. You did really well. The beginning was beautiful. Towards the end, I just want to give you a few tips. You don't have to mention all the incidentals. You're talking about calcified nodes, sigmoid diverticulae, pleural plaques. It's a waste of time. Unless there's something relevant that's, an incidental finding that's relevant. In this case, the only relevant other finding, which I wanted you to say, but it's okay, you didn't, is the NG tube is a bit high up. It's probably at the gastroesophageal junction, so that needs advancing, but that's okay. I don't mind you didn't catch that straight away. But yeah, forget about the incidentals. If it's relevant, talk about it and then talk about it. So what I like to tell people is, the first thing you're doing is you're scrolling through the scan. Then when you find the pathology, you give you're looking at it, your observation first. Then you're going to go to your description. So what are you seeing? Describe it in words, use it, your radiological terminology. Then tell me your interpretation. What do you think this is? So you said, femoral hernia, great. Then you give me your diagnosis. If there's a differential, give me a differential. And then the next step is your management of what you would do next or what you'd recommend the clinical team to do. So just remember, always have that, that structure whenever you get a case, because that's what they want to hear. It's that, nice structure going over there. So you started perfectly. You told me about the dilated loops. You told me about no ischemia, no. You gave me pertinent negative findings. You told me about the hernias in the femoral canal. Then at some point you got confused and said obturator, which is fine because it was just a mistake. And then you told me about the inguinal hernia. So believe in yourself, okay? Sometimes they ask you questions not because they're trying to trick you, but because they want to see how you're thinking. Sorry, Vasha, I'm just going to take control.
Oh, sorry.
No worries. I just want to show everyone the landmark stuff. So the best landmark here is your pubic tubercle to distinguish between a femoral and inguinal hernia. So femoral hernias are going to be lateral to this, whereas a inguinal hernia is usually anterior or medial to this. Femoral hernias are usually smaller, whereas inguinal hernias tend to be larger. And in this case, you see really tight, small hernia. It's next to the femoral vein. It has to compress it, but it can compress it if it gets large enough. And another thing that's important about the femoral hernias is usually typical patient is an old lady, they get the femoral hernia, and the bad thing about these hernias is they don't reduce. They're very hard to reduce spontaneously. So most often than not, they need surgery. Similar cases, obturator hernias too. Whereas inguinal hernias sometimes can actually, reduce spontaneously or with compression, manual compression. So inguinal, the main thing is distinguishing femoral and inguinal hernias. Inguinal hernias, sure, you can divide into direct and indirect. If it goes through Hasselbalch's triangle, it's a direct. If it goes through the inguinal canal, it's indirect. But honestly, I don't distinguish. I don't tend to that so much unless the clinical team really need it. Because a lot of the time they feel for the inferior gastric artery and decide themselves. And I don't know how much it actually changes management, but I need a surgeon to decide that, not me. But yeah, main take-home message here is your pubic tubercle is your landmark. Femoral hernia is the lateral and smaller, whereas inguinal hernias are anterior medial to the pubic tubercle. You also said that the surgical clips might represent a previous procedure. I mean, the surgical clips, they definitely represent a previous surgery, so the previous hernia repair in this area. So this is the first time they've had a hernia. So those surgical clips are exactly where the hernial orifice is. But good job. Just believe in yourself. And if the examiner is asking you questions, it's not because they're trying to trick you. It's because sometimes you did well and they want to give you some extra supplement question, your score up, or just to see how you're thinking. So don't let it phase you. If they start asking you extra questions, just explain to them your rationale, why you think it's that. Don't jump. It doesn't mean they're expecting you to jump to another pathology. They just want to see how you're thinking. So just believe, stick to basics, stick to the fundamentals in radiology that you already know, and just explain to them what you're thinking. Okay.
Thank you.
All right. Good job.
Yep. Dr. Jayakrishan, are you there?
Yeah, hi, I'm here.
We'll load up the next one straight away. I've had to hide the answers on here, so hopefully no one can see it. All right, so this is your case. I will give you control as well. Nicola will be kind enough to give you control. If you request control, I think.
Yes, I have requested.
Perfect. All you. So this is a patient with worsening confusion and headaches.
Okay. Provided with a CT non-contrast axial sections of a patient with worsening headaches, and I can see that there is significant white matter edema in the posterior aspect of the lateral ventricles around the occipital horns. And as I'm scrolling through the rest of the set of images, yeah, I can also, yeah, there's no intracranial hemorrhage. There is no large space occupying lesions. So the presence of predominantly posterior edema, and also the ependymal lining appears to be hyperdense in the posterior aspect as well. I'm looking for a fluid level within the ventricles. I cannot make out any. I'm also looking for any adjacent parenchymal lesions. So in my routine practice, I would ask for further clinical history of this patient, whether this patient has a high BP, or is the patient acutely unwell with high fever?
No fever.
All right. So there are ill-defined hyperdense lesions which are seen along the corpus callosum, which also appears hyperdense. So so to sum up my findings, it's predominantly periventricular white matter edema with hyperdensity of the epidermal lining, and there is no hydrocephalus. So I would convey these findings to the referring clinician. At this point, I'm thinking more in terms of probably an infection would be there, because I probably think of ventriculitis in this case, and because of the presence of the ill-defined hyperdensity in the lining. In routine practice, I would convey these findings and probably do an MRI in this patient for further evaluation.
Okay. The patient's still on the table, so you're on call. The radiographers called you and said the patient's on the table. Can you do anything? Do you want to do anything now, or wait for that?
Probably give contrast.
Okay. Your second scan has contrast. Do you want to open it up on the, yeah, just double click it. There you go.
All right. So I'm provided with post-contrast images of the same patient, and I can see that there is enhancement of the ventricular lining, irregular nodular enhancement of the ventricular lining, and the rest of the findings are almost status quo. I'm looking for any other enhancing lesions. I can see that there's a suspicious enhancing lesion here in the right cerebellar hemisphere near the CP angle. I'm looking for any other lesions as well. I cannot see any obvious other enhancing lesions here in this case. I look at the vessel enhancement. I'm looking at the MCAs and the ICA. In this case, I can see the basilar artery is normal. I'm looking for the ICA enhancement. Probably I'll do that in a routine practice. I do that in a different window.
Okay, the vessels are fine.
Vessels are fine. Okay. So, yeah, I would review the bone window images as well.
They're fine.
So the presence of irregular nodular enhancement of the ventricular lining with an enhancing lesion in the posterior fossa. In my routine practice, I would also check whether this patient is a known case of a primary lesion or primary carcinoma, or whether the patient has any previous history of any cardiovascular illness, whether this could be septic emboli, these enhancing lesions. So
So they have
this could be so my primary differential here would be like a leptomeningeal kind of a carcinomatosis with probably a metastatic lesion in the posterior fossa. And my second DD would be infection, would be less likely because the patient is relatively okay.
Yeah.
Because a patient with these findings would be seriously ill. I would convey these findings and discuss this in the MDT.
Fine. So this was a case of metastasis, basically. So do you have any idea of where the primary may be coming from?
If it's a female patient, probably breast.
Okay.
Male, probably head and neck cancer, thyroid.
Anything else?
Nothing comes to mind.
No worries. Good job. Really, really well done. I like how you tackled those cases really, really well. I'm just gonna show everyone what you said and just give you a few more points, but really, really well done. I really like how you approached everything. So yeah, white matter edema all the way around. You know, it's technically transependymal edema in a way, isn't it? It's going away. It's not the typical transependymal edema you get with hydrocephalus, but it's still leaking through the basically the spaces. Then great, yeah, you talk about nodularity of the lining, mainly posterior, so really, really well done. And then it's fair enough to talk about infection and ventriculitis. I think that's a very good differential in this case, and recommending an MRI is perfect. But yeah, we were lucky, patient had a post-contrast scan, and again, you got all the findings really well. It's nodular, it's, you know, they go all the way around. The nodularity here is what makes you think cancer more likely than infection. Usually with infection, it's more smooth. It can be very thick, and you know, if it's TB or some weird type of granulomatous disease, but not nodular like this. This is too nodular. You need to start thinking cancer. And then really, really, really good job on getting this. I've showed this to about 50 people, maybe like 2 or 3 get it. So really good job on getting that. Great job. And that once you see that, your brain goes, okay, we're talking cancer. So you did it really well. I want to just tell everyone is that when you get a case, so let's say in this case, you got an unenhanced head. The moment you get another case, even if it's related, if it's a different modality, even though it's the same patient and different modality, those are graded separately. So remember that. So let's say you're in the exam, you get this case, and you do really bad. You know, you just didn't feel like you did well. It took time to struggle, but then they give you the post contrast for the same patient. Now you know you've had the time to struggle. Now you know what's going on in the case, and you'll get graded separately. So even if you don't do great on a case, don't feel bad. Don't let it put you down. Just start fresh again, or just remember that every modality or every case is an opportunity for you to get another score, a higher score. And that's why I tell candidates it's quite hard to fail the VIVAs in total, okay? Because you get so many different cases, different modalities, and you're all great radiologists, you all know enough. Just be safe, be systematic, and just let them know that you know enough that you're going to be safe. And that's all they care about. They don't want, you to be the best radiologist and know everything. That's not what they're here for. They just want to know you're safe and you're ready to go to the next stage. So yeah, remember, if you do bad in a case, just brush it off and go to the next one. Don't worry about it. You'll do well enough. And remember, each exam is marked by the other examiner. So even if that examiner is being really harsh on you, it's the other examiner who's actually marking you. So even though that examiner may, be a bit stricter, the other one may be giving you better marks than you think you're getting. So don't let it put you down. Just go there, do your best, and don't worry about it. Okay? Good job.
So what was the primary in this case?
It was lung. That's what I wanted to say. So breast was a very good one. Lung. So the thing about lung cancer is so many people get lung cancer. It can do so many things. Same with breast. That's why you get really weird, things that happen with lung cancer, weird metastases and weird things because lung cancer is just so common. It can do so many weird things. That's the idea. So even though, so it's just lung in this case.
So do we need to recommend spinal neuraxis imaging as well to screen the spine?
I would recommend just a staging scan first. You need to see
Okay.
where the primary was in this case. I think they had a chest X-ray, which showed a lesion, and then they went to have a subsequent CT tap, basically. Yeah, neuroimaging probably only relevant if they're going to treat it. Otherwise, it's academic, isn't it? Unless there's spinal issues or like neurology, and they need to do something like decompress it, then I don't see how they need to manage the primary first and get a tissue diagnosis would be the most priority, unless they have spinal symptoms.
Fair enough. Thank you.
No worries.
Yep. Dr. Priya, are you there?
Yeah, I'm here.
Yeah, hi.
Hi.
Okay. So Dr. Puria, this is your case. So yeah, I will leave it with you. This is a outpatient film in your packet that you're reporting.
Okay, I've been provided with an X-ray left femur, lateral view of a skeletally immature patient. In the first instance, I can see that there's a ill-defined area of sclerosis which is involving the proximal epiphysis of the tibia with a small lucent, well-defined lucent lesion which is seen in the epiphysis. I'll check the rest of the bones as well. The fibula appears normal, and the rest of the tibia appears normal. I'm not able to see any lytic or sclerotic lesion, and the visualized tarsus, metatarsus also appear normal. The similar appearance is seen in the distal epiphysis of the femur, in which the epiphysis appears sclerotic with cosine trabeculae appearance. So there's involvement of the epiphysis of the distal epiphysis of the femur as well as the proximal tibia, and no other lesions I could appreciate. As this is a young patient, my first differentials would be I'll check the previous imaging of the patient, and in my routine practice, I'll check for any orthogonal views if available to confirm these findings.
So you
And
have
to check,
you have a lateral view on the side if you want to load that up. I will provide it.
okay. This is the lateral view of the left leg, which shows the similar areas of sclerosis is also seen involving the talus, the calcaneum, and the cuneiforms. And I think there's also involvement of the diaphysis of the left tibia, mid tibia, and there's a presence of cortical thickening as well. So there's presence of multifocal areas of involvement. These findings could represent first, these could be polyostotic fibrous dysplasia. Second, second differential I would keep as it could be these could be some diffuse sclerotic involvement, which could be some related to maybe myelofibrosis or leukemia, lymphoma. And third, I would keep in a young patient, I'll keep as Langerhans histiocytosis. In my routine practice, there's no evidence of any pathological fracture, and there's no evidence of any soft tissue changes. In my routine practice, I'll check the previous imaging of the patient, take history of the patient and check lab profile. Take if the patient has any complaints and has any history of fever, maybe if these could represent any multifocal osteomyelitis. So and then yeah.
So this was, you asked about previous imaging, so it's been like that on the previous imaging. It looked exactly the same.
Okay, so it was there in the previous imaging as well. So these would be my differentials, and I'll discuss these findings with the pediatric orthopedic team. And I would suggest MRI of the left leg for of the whole leg to look for any other areas of involvement and for further characterizing these lesions.
Okay. So it was like this on the previous films. You still want to do an MRI?
No, I would take a detailed history of the patient and compare it with the previous X-rays. If would have been same, then MRI would not be required. We can just keep the patient on subsequent follow-up on X-rays.
Okay, fine. So it's a tricky case, this one. Thank you, Priya. You did well. I'm just gonna give you some tips and tricks, and also just talk about what it is. So this is kind of an art mini case. In the exam, they've kind of gone away from Aunt Minis now. It used to be a thing of the past. People liked it because it was cool, and you put up a cool case, which is like really rare that they've saved for years. But now more of the cases are more discussion cases because they want to see how you're thinking. And in this case, I don't expect you to get the diagnosis. That's totally fine. But I think what's important here is to say, do you think it's benign or do you think it's aggressive or malignant? And that's a really important distinction. A lot of the time when you get bone pathology, that's what you kind of need to do. You need to know, okay, describe it however you want, narrow zone transition, wide zone transition, use all your descriptive terms. And then at the end of that, you decide, okay, is this a benign pathology? Is this a, malignant or serious pathology, an aggressive pathology that I need to do something about? So in this case, and listen to the examiner. If the examiner butts in and they want to say something, listen to them. They're doing it to help you. They're not doing it because they want to trip you up or so when I said it looked like that in the past, I'm saying that because I want you to go down the benign route, not because I want you to go down the aggressive route. Okay. So you said quite a lot of differentials. And I think it's okay to give, usually I say give about 3 differentials top, but only give differentials if they're relevant or you really do think it's related to it. So polyostotic fibrous dysplasia was one of them. Again, usually with fibrous dysplasia, it's more ground glass changes. It's more of a mixed kind of thing, so not so much. In this case, myelofibrosis and leukemias, again, usually affects the spine first with myelofibrosis, and then it gets quite sclerotic. So again, quite unusual to be in the long bones. Langerhans cell histiocytosis, again, this will have the polyostotic version, and again, it's usually more lucent and not so much sclerotic. And I think you said a few other things as well. Multifocal osteomyelitis. Again, you expect, patient to, have waxing or waning appearance and coming back in with like, pain and fevers and all those things. So again, this is a case of just what we call meliostosis. So it's a typical finding of, your dripping candle wax sclerosis going all the way down. And, if you've seen it once, it's easy to remember. But if you haven't, then again, it's tricky in exam, and that's okay. They don't expect you to know about Antimonies and say the diagnosis. But what will get you a pass or get you the mark is just to say, yes, it's sclerotic. This looks benign. I don't see any periosteal reaction. It's a narrow zone of transition. Overall, I think this is a benign pathology, maybe something congenital or metabolic or whatever. And that's pass. Everything else is just to get you the 7s and 8s. But if you just say that, that's a pass. And that's all they really want to hear from you, that, you can distinguish, is this a benign or is it malignant? And then saying an MRI, only do that if you were concerned about something malignant or aggressive, because the whole idea of MRI is, we don't want to just be scanning people unless we're doing it for a reason or it's going to change management. So if you're thinking something's benign and it was like that in the past, what's an MRI going to add? It's just going to waste hospital resources and do an unnecessary scan, which is something we want to avoid. So if you're recommending other modalities or imaging, make sure you're doing it for a reason and state why you're doing it essentially. But good job. Tricky case again. Another on mini, but like I said, it's kind of gone away from doing this exam. That's not to say you won't get it.
Is there only involvement of the tibia, or there's epiphysis involvement of the femur as well as
Everything,
the
everything's
talus and
involved.
calcaneum? Everything is involved.
Everything's involved. So it usually just it doesn't respect it goes through basically growth plates. It goes across the joints. It doesn't respect, and it's usually bilateral, and usually you get on multiple bones. So if you had a view of another bone, it'd probably look very similar as well. But yeah, meliostosis, dripping candle wax is the path, well, the buzzword that they like to use. But yeah, tricky case, but good job. Just remember again, slow it down just for you, Priya. Just slow it down a little bit. And if the examiner is speaking, let them listen to what they have to say, because they're there to help you and try to give you tips about where they want you to go. So listen to what they're saying. So when I said it was like that in the past, I'm saying that because I want you to go down the benign route. Okay.
Okay.
Dr. Ahmed, are you there?
Yes, sir. Can you hear me?
Yeah, I can hear you. Yeah, cool.
Okay.
Okay. This is one of my favorite cases, Dr. Ahmed. So enjoy it. I'll start. I'll start with the plain film, just because we do that a lot as one exam, where they'll start with a plain film and then move to the CT of the same patient, or they'll start with a scout image and then go to the CT. I just want to see how you work for both of the cases. So
Right.
we'll start with the plain film and then take it from there. So here's your case of a patient coming in with worsening cough.
Okay. This is a frontal radiograph chest of an adult patient in which I can see that in the both lungs there are soft tissue density nodular opacities that are seen in all the zones of the bilateral lungs, and I cannot see any evidence of calcification or a cavitation, and these are there is no definite zonal predominance of these nodules, and the costophrenic angles are clear, and the trachea is central, the aortic knuckle appears normal, and uh, the right hilum appears dense. However, I cannot see any definite nodular contour or lobular opacity. The heart size, although the borders appear shaggy due to these overlying opacities, but I cannot see any evidence of cardiomegaly. I'm looking at the bones, uh, the clavicles, scapulae, uh, proximal femora appear normal. The diaphragmatic contours are normal, and I cannot see any evidence of a vertebral abnormality. The overall density of the bones appears reduced. In conclusion, for this appearance of chest findings, I am thinking about differentials for mealy nodules, which include metastasis. I would be concerned about any previous history, whether this is a known patient of any primary malignant tumor elsewhere in the body, or it could also be an infective etiology like tuberculosis or histoplasmosis, although I cannot see any cavitations. And other than that, it could also include pneumoconiosis. Uh, Although in the pneumoconiosis there is a zonal predilection like upper lobes, except for the asbestosis, other pneumoconiosis are upper lobe predominant, and uh, I would correlate this with the history and do an HRCT scan for further evaluation.
Okay, fine. So patient's been admitted to A&E. They're getting more unwell. The cough is getting worse, and they're now short of breath. What would you suggest? HRCT or something else?
Patient is getting more unwell, sir?
Yeah, so they've been admitted to A&E, so the emergency department, and they are more out of breath now, and they're desaturating. What would you?
Okay. In that case, I would recommend chest intubation and oxygen therapy, and might have been be might have to be put onto the ventilator, and first we would manage the oxygen saturation levels and then decide for further management.
Okay, but you're a radiologist. I hope you're not giving people oxygen and ventilators. What are you
Right.
doing radiologically? What would you suggest? You initially mentioned your HRCT, but given the new history, would you recommend a scan? What type of scan would you recommend as a radiologist?
Uh, Ventilation perfusion could be,
Okay,
but
fine. So with a HRCT, you're not giving contrast, are you? It's just an unenhanced scan looking at the lung parenchyma essentially in high resolution is the idea. Would you
yeah,
give contrast or not, is what I'm getting at. And if so, what phase would you like to give the contrast?
arterial phase.
Okay, why?
Uh, because I want to see the enhancement of this as compared to the pre-contrast image,
Okay.
and it would also show the status of pulmonary arteries.
Okay. So as in arterial phase, as in arterial, as in
Sorry, it would be in the aorta.
in the aorta. Then.
In
So would you see the pulmonary arteries?
Yes.
Okay. Fine. Do you want to load up the scan? You've got a scan on the top, the CT. You can load it up.
I have requested for the
Oh yeah, sorry. There you
remote.
go. I will load it up for you to help you, and you should have control.
I have it is a bit lagging behind. Yes, now it is okay.
So same patient, same history. Here's your CT.
Okay. So this is axial section CT scan, mediastinal window of the same patient. I am scrolling from the top towards the inferior part of the chest. I'm looking at there are nodular opacities in the right lung. I'm looking at the mediastinum. Few small lymph nodes are visualized. There is an abnormality in the right upper lobe. I would look at it once I've scrolled through the image. There are multiple nodules seen in both of the lungs and the heart and the descending thoracic aorta do not show any evidence of any abnormality. The breasts appear normal. Okay, so I'll be going back to that abnormality.
Which abnormality?
So this one.
Okay.
There is a soft tissue density lesion seen in the right upper lobe that has irregular margins. And in my routine practice, I would look at the pre-contrast and determine the enhancement of this pattern if this lesion and the irregular margins of this lesion are more suggestive of malignant etiology. And this is abutting the mediastinal fat, and there is loss of the fat plane between this lesion and the mediastinum. And I would this I would consider this as a malignant lesion of the lung, with possibly the other nodules representing metastasis. And in my routine practice, I would also look at the lung window and at the bone window for lung and osseous.
You can put it in lung window. Just click on window on the top and put it in lung. I'll do it for you. Just give me a second. Lung. There you go.
Yes. Okay. So this is the lung window, CT axial of. Yes, now it is moving. CT axial of the same patient. I'm looking. There is an area of mosaic attenuation in the left lung, and I can see on the right side that there are multiple subpleural cysts seen, and also there on the left side, and these are more marked on the right side. And also I can see that the subpleural cysts are seen in the posterior basal segments of both lower zones. There is evidence of traction bronchiectasis, particularly on the left side. And these changes are more marked toward the lower zones of both lungs.
Okay.
Therefore, in conclusion, for this appearance of the lungs, my primary differential is idiopathic pulmonary fibrosis. I would correlate this with the history of the patient, whether there is any history of other connective tissue disorder like rheumatoid or any other history of whether the patient has been on any drugs. And uh, I would my primary differential is idiopathic pulmonary fibrosis or usual interstitial pneumonia.
Okay. Did you see anything else on the scan, or is that it? Are we done?
Okay.
That's okay. Just for the interest of time.
This lesion.
Yeah,
This
you're
lesion.
Don't worry, Ahmed. Thank you so much. Just for the interest of time, I'm gonna work this case out for everyone. This is quite a complex case,
Right.
but I love this case, and I'll show you why. So we'll go back to the beginning. So great job on the X-ray, though. Really, really well. You said, you know, nodular opacities. You know, I think it's more, you know, nodular is fine, but reticular nodular is probably a bit of a better term because, you know, there's a lot of you can see some reticular and nodular opacity, so it's kind of reticular nodular, but that's pedantic. It doesn't matter. You gave me lots of good negatives. And you're talking about this right hilum, so really good job saying the right hilum is a bit more dense. And then you gave me some differentials about miliary nodules. You could have also mentioned interstitial lung disease in this case as well. I think that's fair enough. And then yeah, the next thing is go to the CT. So what I was getting out of the CT is what type of scan to do next. I mean, sometimes ask you this a lot. They'll ask you, you know, what do you want to do next? And they just want to see how you're thinking, what type of scan and why. They want to see your rationale and how you're vetting these scans and what your brain is processing. Sometimes they'll ask you as well, if you get an MRI scan, like what sequence do you want to look at first and why? There's no right or wrong answer. As long as you can rationalize why you're doing something, it's okay. They just want to see how you're thinking. So what I want you to say here is, I told you the patient's unwell, they're in A&E and really saturating. I want you to say a CTPA. I want you to say a CT pulmonary angiogram because you're worried that the patient could have a clot, essentially. An arterial phase scan, when we say a CT, a chest and arterial phase, usually that means that we basically got the contrast in the aorta, not in the pulmonary vessels, but we want a CT pulmonary angiogram because, you know, if we do just a HRCT and the patient's unwell, we're going to miss a PE. So in this case, which is why it's such a great case, is there's three things in one. So the CTPA, you've got multiple filling defects in the lower lobes, which is what I want you to see, which I asked, is anything else on the scan? And, you know, so a lot of the time in the exam, I said, like, they don't try to fail you. They really do want to pass you. There's only some times where the specific cases is what they call, like, you know, I don't know if this is true, but I've heard it as a rumor, as like they call them fail cases. And it's just, if you don't say something that's life-threatening, then they have to kind of fail you for that case because it's impossible not to. So things are like missed dissection. If you miss an aortic dissection, life-threatening, they can't do it. PEs, you know, you got to be careful. If you miss a large PE, again, it's dangerous. If you miss a tension pneumothorax, if you miss, you know, life-threatening injuries or life-threatening diseases, that's the only time where the examiner, you know, their alarm bells go off and go, okay, you know, I know it's an exam, we all get stressed out, we're gonna miss things. Even in real life, we miss things. It's natural, but it's just hard when you're an examiner to pass someone who misses a life-threatening thing. So just be really careful, guys, when you're in the exam, to stick to your basics and don't miss the life-threatening stuff, because that's the only way that, you know, if you mess up a nodule here, or you know, you don't describe the, you know, UIP picture and you say NSIP, that's fine. You still said it's interstitial lung disease. They won't fail you for that. But if you miss a P or aortic dissection or something life-threatening, it's not great. Anyway, so in this case, a really good case. So yeah, so you've got bilateral Ps going all the way down. You've got an element of right heart strain as well. The interventricular septum's bowed, your right ventricle is distended. And then on the lung window, so yeah, you were talking a lot about the lungs in the mediastinal window. Don't do that. Tell the examiner, I want to put in the lung window. Because if you don't tell them, they won't let you do it. So say that, I want to look at the lungs in the lung window. Then they'll say, go ahead. But if you don't say it, they won't do it. Or they'll say focus on the mediastinum first, which is totally fine. Then they're telling you to focus on something else. So listen to their cues. What are they telling you to do? And they're trying to help you. So in this case, really well done with descriptive. So yeah, there's all these reticular nodular changes going all the way down. There's cystic changes or honeycombing in the lung bases, and there's traction bronchiectasis too. So be careful. You said idiopathic pulmonary fibrosis. This very well may be idiopathic pulmonary fibrosis, but we don't, as radiologists, we don't give that as a diagnosis. Your job as a radiologist is, okay, this is interstitial lung disease, and then you decide, is it a UIP type, so usual interstitial pneumonia, or is it more NSIP type picture? And in this case, it's more UIP. And that's what's important. Then they'll decide, okay, they'll take it to the MDT, the interstitial lung MD, and then they'll decide, you know, getting all the clinical history together, the bloods and the picture, and then decide, okay, is it or not? And the thing about idiopathic pulmonary fibrosis is usually a diagnosis of exclusion. And the reason so is because it's such poor prognosis. They want to rule out all the other things that they can reverse or change or treat first, before you give labeling a patient idiopathic pulmonary fibrosis, it's almost like saying they have, end-stage lung cancer, because the prognosis is so poor. The moment you label someone as idiopathic pulmonary fibrosis, you're essentially saying that, there's not much we can do. Their lungs are going to become fibrotic until they can't breathe anymore. Unfortunately, that's what happens. So in this case, it's UIP type picture, and that's good enough. And then, yes, really good job. You've got the spiculated cancer here, lung lesion, and then you would recommend lung NDT and biopsy and all those things. So this is a really cool case because the reason is the primary problem they have is idiopathic pulmonary fibrosis, which, the fact that you've got, UIP type picture. In this case, it was idiopathic pulmonary fibrosis, but just be careful when you label a patient with that. And what happened is that increases your chance of getting cancer, because any chronic inflammatory disease increases your chance of getting cancer. And then they got cancer. And then any cancer increases your chance of getting clots. And then they got a clot because of, their cancer. So it kind of all ties in together, which is why it's such a beautiful case, 3-for-1. But yeah, tricky case, really, really difficult one. But you work through it well. Just be careful. Don't miss those life-threatening injuries or diseases, because that's the only time where their alarm bells could go off. Okay?
All right, thank you.
No worries.
Dr. Paymon, I think we've been doing it for a while, and I think you must be really tired considering the fact that you've just come back from work. So
I don't mind though. I enjoy teaching. As long as you guys are learning and you're finding it useful, I'm happy to do one more case at least. But it's up to you, Nicole, what the plan is.
It's fine. It's fine. If you are okay, then we can do one more case and then probably wind up with your feedback for
That
the
sounds
conference.
perfect.
Yeah.
If everyone's, we'll do one more just for the road. I'll pick a juicy one.
Let's see. I think Dr. Vivek, are you there?
Hello. Hi. I'm here. I'm here.
Yeah. Hi, Vivek. Yeah.
Okay, another great case. So I'm trying to pick the juicy ones for you guys. Things you probably don't see very often, but it's good to just work through it. So if you request control, I will give you control.
1 minute.
And we'll
Requesting for control, please.
so Dr. Vivek, your case. It's a patient with abdominal pain.
Okay. So let me just scroll it from the top. Right. And visualized lung basis, I don't see any effusion. There's evidence of nasogastric tube with its tip. With its tip in the proximal stomach, although I think it's projectional, so I think it's well within the stomach mucosa.
Don't worry about the NG2, it's fine.
So it's a contrast enhanced CT abdominal. Also, the oral positive contrast also has been given to the patient. I quite see dilated small bowel loops with airflow level, and contrast is reaching just pardon me for the, I think I have a slow internet or
Yeah, if you wanted to go faster, just click on the bar on the side and then pull it down. It goes faster.
oh yeah. Yeah, so okay. So let me just scroll back once again. Oh, there was a jump. Okay.
Want me to explain what you're doing? Just so I know.
Yeah. So there is evidence of diffuse bubble wall thickening, small bubble wall thickening in the terminal ileum. I'm just seeing the cause for dilated bubble loop there. I'm just looking for the transition point. In the pelvic region, I also see some mild ascites. Right. So contrast has reached till the terminal ileum, although ileocecal junction is fine. It's the large bubble loops are the transverse colon, descending colon, even the ascending colon as well appear normal.
Okay, I agree.
There, yes. So and I see dilated bubble loops, although I'm not able to quite clearly delineate the transition point for the reason of small bowel obstruction.
What about that area there?
I-
You were talking about some thickened terminal ileum. Do you want to focus on that area and describe it to me a bit better?
Yes, sir. There definitely there is bubble wall thickening in the terminal ileum with likely predominantly in the mural region. It can be, I don't see, irregular circumferential thickening there, but it I do see smooth enhancing thickening of the bubble in the probably in the proximal ileum with surrounding fluid, which could be the cause for narrow zone of transition point causing the obstruction. I do coming to the uterus and adnex.
Don't worry about it.
Okay.
So is there anything else in the upper abdomen that may help you? Do you want to look at the organs in the upper abdomen quickly and tell me if there's anything there that looks unusual?
Yes. One unusual thing is I see some kind of C loop here in the pelvic region. Although I would, in my normal routine practice, I would see in all the three planes in coronal.
So that's just a dilated loop associated with the disease. I do want to go to the upper abdomen and tell me if there's anything unusual about the upper abdomen.
Okay. Well,
So upper abdomen, the solid upper abdominal organs. How do they look?
the liver appears normal.
I agree.
Gastroesophageal junction, the stomach appears normal. Duodenal, and the duodenojejunal flexure.
Don't worry about the bowel and just focus on the solid upper abdominal organs. So what are your solid upper abdominal organs? You said liver, I agree.
Okay. Kidneys per se,
Okay, they're fine.
they are fine with good contrast enhancement. The spleen, the lower pole of the spleen, no, there I don't see quite an enlargement of the spleen coming to
I
the
agree.
adrenals.
Yeah.
Both the adrenals look fine to me.
I agree.
Coming to the pancreas, yes. Right, there is fatty replacement of the pancreas. I do see the pancreatic duct clearly till the splenic hilar region. Yes, so let me just see if there is, then there is over-distended gallbladder. I would
Just focus on
like
the
to,
pancreas.
yes, so constellation, summarizing my findings, there is fatty replacement of the pancreas with smooth bubble wall thickening in the terminal or proximal ileum causing small bowel obstruction.
Okay.
I would like to think a possibility of my first probable diagnosis is that of a cystic fibrosis. The then second differential would be autoimmune condition, although very unlikely that the pancreas would go a fatty replacement there.
Perfect. And what do you
I-
do you know if this was in a child, what would you call what would you call the pathology in the bowel? What would you
The constellation of findings, this would be a case of cystic fibrosis. I would inform my findings to the referring physician, then immediately because of the fact that the patient has abdominal pain, so because and also small bowel obstruction, so that she could be relieved of the symptoms. Then also compare it with the prior studies, and further work up the case for the cystic fibrosis. Although I would also see for the lung changes, maybe I would see it in the lung window if the case of the visualized lung.
Okay, good. Fine. Good job. Tricky case. You worked through it very well. So I'm just going to work through it quickly. Yeah. So there's all contrast. And then what's important here is that the contrast stops in this thickened area of the distal terminal ileum. And that's what's important here. So that the contrast stops. There's no abrupt transition point, I agree. But you've got all this thickened secretions or thickened fecal residue in there and thickened wall with all the ascites and fat running around. So even though there's no proper transition point, this is our transition point. It's not abrupt, but contrast isn't passing and it's thickened. You've got all the small bowel obstruction proximal to this. And then, what gives it away here is the pancreas is missing, or what we call lipomatous pseudo-hypertrophy of the pancreas, which is basically the way you distinguish this from like pancreatic agenesis is the duct. So they have a maintained duct, but the rest of the tissue is replaced by fat. Whereas in pancreatic agenesis, everything's gone. Basically, there's no duct and there's no fat, and everything just takes its place. But with pseudo-hypertrophy, lipomatous superhypertrophy, you get this beautiful appearance of fatty pancreas with a duct going through. Right. And then, like you said, this is a case of cystic fibrosis with distal intestinal obstruction syndrome in adults. So usually distal intestinal obstruction syndrome you get in pediatric population, very rare to get in adults. But this is a case of that, which is a really cool case. I've never seen anything like it, but a nice one to have. Good job. Tricky one, but really well done. Good job, everyone.
Thank you, sir.
So I think we'll call it then. I'll leave it to you, Nick, if you want to finish up, and I'll just remind everyone to please check out RAD Bites and try it out and let me know what you think. I really do appreciate feedback, guys, and thank you, Nicole and Dev, for having me on today. I hope you all found it useful. I hope I taught you guys something or we learned together, and hopefully maybe I'll come on again if Nicole wants me to.
Yeah, I think it was a lot of cases were very interesting, and I think your feedback has definitely helped all these candidates for planning for the September exam. And I think they would want you back in the coming days. Yes, I think I can see a few comments on that. So we would definitely plan on that. Having said that, guys, please check out his website, RAD Bites, and probably I can convince him for a discount probably for a couple of candidates who can come in early on a first come first serve basis, so that they can kind of experience his resources. And that's it. If there is any more questions, you can feel free to comment in the comment box, and then we can address it.
That's true. I think there's a lot of messages I've completely ignored. Let me see if there's anything important.
I think, Dr. Paymon, if you could share your email address in the comment box so that they can personally text you and inquire things with you with respect to the exams and your resource like RAD Bytes, I think that would be really helpful for them as well.
Yeah. So you can also contact me directly on this page. I will read the comments on here. It's probably the best way, and I will get back to you. Otherwise, social media is another way. If you just click on here, it'll take you directly to RAD Bytes Ed. You can message me on there as well. Probably the best ways. I'm available different ways. If I take a few days to respond, I do apologize. I do work full time and have 2 kids drive me crazy. So feel free to. If I take a few times, I'm not ignoring you. I just probably just need some days to get around to it. Okay.
Yeah, great. I think we have a couple of questions from the Rapids. I think we can address them, yeah.
So a few questions I missed out before. I will try to answer them all as quick as I can. Let's see. Fine, fill out form. What time is going to be? Form analysis, good job. Actually, you need to mention about retrocardiac capacity. I didn't see, there was no retrocardiac capacity in any of the cases. Interesting case, thank you, blah, blah, blah. Distance, really good job. Distance test obstruction, great job. What was the diagnosis? So the epiphyseal sclerosis, it was also the diaphysis was also what we call drip candle wax, or cortical thickening all the way down. So yeah, meliostosis, someone already wrote that. Perfect. While we're putting edge of the film dislocations, how sure do we need to be? Because sometimes the clinician can stimulate a dislocation. So again, you have to be sure. So a lot of the time, a good case is where you have like kind of 2 bones overlap. I think I have a great example of that on here. So on the hand, something I've stimulated. So yeah, so usually the only time it can be a bit subtle is where you have this bony overlap. But again, you'll have multiple views. So you'll look on both views and then you'll see, okay, there's a dislocation there. And again, if you're ever unsure, picture yourself in a group room of other 5 radiologists, and if there's uncertainty or ambiguity, don't call it. It has to be a dislocation. It can't be ambiguous. Skull fractures are always traumatic to report. Any trips? So with skull fractures, again, a quick one. So if you just go to the skull, it's probably the best way to show it. Face. So with skull, what I usually advise is the main things you're looking at is, okay, you've got your elephant trunk, your zygomatic arch, your frontal process. Focus on this area. It should be nice and symmetrical. Look for fractures and breaks. Look at your inferior orbital floor. Look for your secondary signs of orbital emphysema and your maxillary sinus for any hemosinus or any blood in the sinus. The rest of an X-ray is really hard to see anything unless there's something obvious like a really big mandibular fracture or some cyst in the mandible or something huge in the skull like a huge lytic or sclerotic lesion like a meningioma. You're not going to be able to comment. You're going to be very risky if you're trying to talk about something here and posteriorly in the skull because there's so much bony overlap that you're not going, you're just taking a chance. So remember, it's just mainly what you're looking for here is, are there any fractures? Are there any orbital emphysema? Is there any hemosinus? And is there anything else that's obvious? Otherwise, chances are there's nothing on it. It's normal. In the case of malignant fracture on X-ray, should we do staging CT or an extended biopsy? So that's a good point. So with fractures, it depends. If it's a malignant fracture and you know the primary, then it's different. If you don't know the primary, then yeah, they'll need a full workup, staging scan. If it's sclerotic, then they'll need PSA and bone scan to look for prostate stuff. If it's a primary bone lesion, you're not sure, you did a CT tab and you can't find it, is very, very careful. You don't biopsy primary bone lesions because you have a risk of seeding. So whenever there's a case of, a primary bone lesion or a sarcoma, these get taken specifically to a sarcoma center or a tertiary center, and then they decide, okay, what are we going to do? Are we going to biopsy it locally? And then they'll give you the recommendation to the local team about how to approach it, or they'll take the patient on themselves and decide what to do with that bone lesion. Because the thing about it is you don't want to seed. And if they're going to operate, they want to make sure that the track that's there, they'll remove everything from it. So yeah. But yeah, I think that's all I have time for, guys. I'm sorry. And the VQ scan can be done as well. So VQ scans, we don't really do them that often. The reason is CTPA is the gold standard now. And also VQ needs to be that the hospital has availability that they can actually do VQ scans, and not a lot of hospitals do because you need a pharmaceuticals, and a lot of hospitals do it. It used to be that they used to do that for, pregnant ladies and all that, just do a perfusion scan. But they kind of stopped doing that too. We just tend to just CTPA everyone nowadays. It's just quicker, it's the gold standard, gives you an answer. And for bone scans, what are the standard indications? So bone scans, it depends. Usually it's for sclerotic metastases because you're looking for, most of the work is going to be for prostate cancer workup. Sometimes they do it for other stuff as well. And sometimes you find other stuff that you're not looking for, like, lytic lesions form as a photopenic area, or sometimes you get like the super scans with like, renal diseases or, disseminated malignancies too. So it just depends on, I'm not a nuclear medicine expert, so a lot of my understanding of it is very minimal, but we do a lot of bones for prostate cancer.
Great. So I think we are done with the questions. So probably we'll wind up in another couple of minutes. Yeah. Thank you once again, Dr. Paymon, for sharing your time with us and sharing your feedback. I really hope to have you again with us. Let's plan something soon.
Just message me. We'll try to work a day with my schedule and around them, and we can make something work. Yeah.
Absolutely. Yeah. Thank you everybody for attending the session, and hope to see you guys for the next session soon. Yeah.
Bye everyone. Nice to meet you, Nicole. Finally. See you everyone. Bye everyone.
Bye.